I'm thrilled today to invite one of my colleagues and friends, Carlos Castillo-Salgado, who is a physician and also an epidemiologist. He's a professor epidemiologist at Johns Hopkins University Bloomberg School of Public Health. This session today is going to be focusing on perspectives from Latin American epidemiologists, and I know you're eager, especially with the Washington Post article that came out this morning, very eager to learn a little bit more about that. Very brief introduction about him. His many accomplishments at the Pan American Health Organization include the development of one of the most important strategies for controlling malaria in the Americas, as well as the World Health Organization, Pan American Health Organization's Regional Core Health Indicators Initiative. He has developed advanced training programs that set a gold standard for professional epidemiology worldwide and taught thousands of Latin American and Caribbean public health professionals, senior international health advisors, and academic and health leaders. And he's actually won teaching awards. And so I'm sure we are all looking forward to his presentation. This is a continuing series of seminars that we're giving on the epidemiology on the COVID-19 pandemic. You can access the previous ones that we have provided online at our University of Maryland School of Public Health website. Those of you who have linked on, we'll make sure we share that link in the chat box so you can grab that if you're interested. And we encourage you to participate in our future events that we're going to be having. Next week on Monday, we're going to be talking about the impact analysis platform for situational awareness and decision support on June the 9th. On June 26th, we're going to have Dr. Oscar Allende, who's going to talk about best practices of states and counties in addressing the COVID-19 pandemic. And then on July 7th, we're going to have a presentation from both Australia and from the United States on indigenous perspectives on COVID-19. So stay tuned for that. Now, at this point, we have a brief welcome we'd like to show from our Dean of the School of Public Health at the University of Maryland.
Hi, I'm Dean Boris Lushniak, and welcome to the special seminar series on the epidemiology of COVID-19. This is an incredible moment in history for us to be tackling the pandemic of COVID-19. And what a great opportunity for us to be able to work together and to educate each other on the pathways ahead. First of all, thank you much to the organizers of this seminar series and for having this forum for us to be able to exchange ideas. Over the next few days, you'll be listening to experts in the field who want to have an interchange with you, an exchange of ideas with you through the webinar that we're presenting now. In the next few days, you'll be hearing from Dr. Olivia Carter-Pokras, part of our faculty here at the University of Maryland. You'll also be hearing from Dr. Travis Gales and Chung-Fu Liu from the Montgomery County Department of Health, who are out there in the front lines of public health action against COVID-19. And then finally, you'll hear from our esteemed chair of the department, Dr. Hongjie Liu. So this combination is not just about that foursome presenting to you, but it's the interchange of ideas in the midst of a public health crisis. We learn from each other. So let's utilize the seminar series to get better at what we're doing. Thank you very much for attending this, and let's learn together.
I would like to ask everyone, so Dr. Carlos Castillo-Salgado can go through his presentation. If you can hold your questions until the end of the presentation, you can share them on the chat box and we can then repeat them so everybody can participate that way. And you can also raise your hand and we can call on them. So our format is Dr. Carlos Castillo is going to give his presentation first, and then we'll have time for questions and answers. Thank you very much for being here. We look forward to the remarks.
Excellent. Thank you very much, Olivia. I really appreciate it. And it is a very important type of presentations that will allow us to share some of the knowledge and the experiences that are happening, particularly in Latin America. Let me also now bring the PowerPoint presentation that I will be using to illustrate what is happening with this new chat that was developed by 80 epidemiologists across Latin America. Very good. Uh, the the agenda that I have for this afternoon is to address several issues, including what is the background and why this very important technical chart was developed, and some very brief lessons that are very important for us from the influenza pandemic of the last century, why we are now implementing a lot of the tools and metrics from the international health regulations. Then what are the type of activities from the 80 epidemiologists, the challenges that are faced by Latin America, and some of the lessons learned. The first thing is I want to give you the very brief overview about these 80 epidemiologists. These are part of our training program for senior managers in Latin America. We have been training almost 500 professionals, including presidents of Latin America, several ministers of health, all the national directors of epidemiology has been passing from this very important, very complete training program that was decided to increase the ability of the senior public health managers to address epidemiology for completing most of the tasks. And this is the only all full-fledged Spanish program, 11 months at Hopkins. This technical chart was developed originally with several of the epidemiologists from the cohort of 2016, 17, and 80, and immediately was growing into 80 epidemiologists from 20 countries. They started recognizing as a forum for real-time information about several things that are presenting in these slides. Regarding the lessons, I want to emphasize that any novel virus or disease, we don't have the ability to control through the drugs and the vaccines. And the lessons learned is that all the measures that we are now implementing are not new, are the only viable and effective interventions. And I see what happened during the pandemic. We see here some ladies walking on the streets. And I want to share these two very relevant and interesting information. The first one is one of the magazines in Argentina, in which represent all the interventions that were needed, the social distancing, as you see, the men with two things that are being used to minimize the contact, the lack of, the interest in not handling the hands, the using the different of the measures that we are using, even the mask, etc. And on the right, this is the official statement from one of the towns in Mexico, in which again, in 1918, implement exactly the same measurements that we are using today in our pandemic. I want to take also the opportunity to indicate that public health needs to recognize the role of epidemiology. We are the ones that develop the natural history of the diseases. Historically, COVID natural history was done even in very few weeks, when AIDS took a decade. Then it's very important for us to recognize how the science and the epidemiologists have been working extensively to provide all the assessments, tools, and metrics that we are using now. Even the information about the incubation period that was essential for the characterization of the infection and the dissemination of the COVID. But very important to recognize that epidemiology is also critical and important to recognize the vulnerable populations. And here in the United States, as you know, the Hispanic population and the Afro-American population has been disproportionately affected, and the vulnerability has been extremely high. This is the very brief linkages of the globalization and the need of the health regulations of the 2005. As you see here, now we have a challenge that the transportation of people and merchandise is so fast that it's even shorter than the incubation periods. Then once the dissemination of the cases are done by different people through the air traveling, we have already the inclusion of the world as vulnerable as we see now. Again, in early January, this group start to share a lot of the information and the recognition, what were the standards, the definitions, and was very much expanded very soon. And I put several of the brief messages that they start having to share a lot of very important information. And also the recognition of what happened in Spain, since we also include in our network Spain. All the information about the first cases in each country has been exchanged before the international news, and even the World Health Organization has been capturing. These epidemiologists share the information in advance and start giving some advice about the importance of the communication and having some of the interventions in other countries. Also recognizing that there was a lot of wrong information or information that was disseminated in Latin America, particularly in very poor groups, indicated that there were some treatments that were effective for COVID, as we know that was not the case. Here we have some other very important exchange of the trends in different countries, and again, some of the rules that are changing in the countries. This was, as I indicated, every day we have at least 20 to 30 exchange among the different participants. Also, they start recognizing a lot of the background information and the factors or cofactors that have been affecting the transmission in Latin America. A lot of the problems that these epidemiologists have been confronting is that the national authorities were reluctant to accept that the COVID was a very serious problem in their countries. Again, the information of Brazil was very important. I need to inform that Brazil had one of the best surveillance systems of the world. They have real-time online. However, the president disestablished that system, and unfortunately, 2 ministers resigned, and our colleague that was the assistant director for surveillance that has been highly trained just resigned a few days before, because they don't want to implement the authorities, the true interventions that are needed in the countries. Here is the comparison of the first cases that appeared in Spain and what happened in the type of testing in Brazil. Here also, I want to share that sometimes they were monitoring the information that was presented in the web by the countries. The the Ministry of Health in Argentina made a big mistake. They put the comparison of the country indicating that the second was with more cases and deaths were Chile. And the statistics were corrected because originally they say that was per 100,000 when in fact was 1 million. With this exchange, immediately the Minister of Health corrected the information. The other thing was very important is that there was a lot of products that they were pushed by the industry to sell to different countries, like these disinfectants that were not more effective than even the chlorine and water. And sometimes one country asks to other, and here they are saying that this company that is pushing a lot to the authorities, they didn't have even the health registration of their product. Now, I want to see that it's important for us to recognize what are the economic trends in the regions that will explain about the vulnerabilities and why now we are starting to face a lot of problems in Latin America. This is the very important assessment from the turn of the century from the Economic Commission for the Latin America and Caribbean, ECLAC, indicating all the problems that are in the economy even before of the pandemic. Then the contraction of the economy in all the countries is partially the reason why some authorities in different countries were putting the economy in first than health. See, you see that another very important consideration is that more than half of the workers in Latin America are in the informal work. And informal work, they don't have protections, they don't have the ability to receive some funding, they need to work daily outside. And this is a very serious aspect that these people will die of even the inability to eat. And then since it's so large in different countries, including Bolivia, Peru, Mexico, Colombia, then it's explaining why the population is taking more risk than in developed countries. The informal work then is one of the main reasons, but also how much affected are the micro and the small companies and groups. This is also that most of the countries lives from tourism, and since that is the main activity, many of the countries are now facing a lot of economic problems to sustaining the basic economy. I want to share, this is a very important consideration for us. Although the United States is in the same group, Latin America, particularly Mexico and Brazil, delayed the change for phase 1 to phase 2. We pushed the authorities to go into moving because it took months when they already have, and you see these graphs in the left from the Brazilian observatory and from the Mexico observatory, how many weeks they wait to declare that the COVID was actually an epidemic in the country. They took it as important cases, and when I discussed with some of the authorities, they mentioned all are imported cases, then we would not be moving. And we knew that that was not the case because they didn't have even the labs, they didn't implement the testing. Then how they did, how they recognize only the idea that all the cases were imported. And as such, you see what is being happening. Here is very clear, as you see from the January to April, they did nothing in Mexico. And the cases were increasing and increasing, and the authorities decided, no, we will not go into the second phase. We will not inform the population that we are in the pandemic. And here is what is now happening. The trends, if you see from March to April, you will see that they kept very low, and basically they kept very low because they were not testing. But it's interesting, the approach from Colombia. As you see here, they are not in the peak. They already recognize the peak. However, there are many vulnerable areas and population groups in which the transmission still is intensive. What is this very important? These graphs are national graphs and present the national vision. But what is happening in specific areas, that's a different story. We are now moving into the local level epidemiology and surveillance. As you could see, the interventions need to be adjusted by this local epidemiology. Obviously, we need the national, but the national will give us the picture of the nation, but not of the specific areas of cities. This is the past minister, the previous Minister of Health, Jose Narro, indicated that Mexico was not prepared for the pandemic. This is interesting because he emphasized how important was to have the testing and a different approach. Mexico changed, dismantled the surveillance system that was national for 20, 30 years, and they decided to go into Sentinel, means that they didn't want to test all the places. They select only 400 places in all the country. Then now they are facing of a tremendous problem because they don't know which cities and municipalities have more cases since they never tested there. And I just received in the middle the new graphs in which the projections that were done by the government was totally wrong. Yesterday, they have 4,000 new cases in Mexico. They were saying, as you see in the projection of the government, that we are now in the plateau in which almost no cases should be appearing. And one of the epidemiologists present the different models, and the models that are more fitted is the worst one that is called the Cora MEX, in which expect the peak to July 11, in which will be a tremendous number of new cases, and is expected to have 500,000 cases. Again, the independent that they had more cases and that they don't do a lot of the testing, even the testers and the testing was interpreted as not needed by the assistant minister. That happens also in Guatemala and in many other places. This is very interesting that the mobility was assessed, and I want to indicate that they use a lot of the metrics. Here is the changes in the dining, in the driving, in the walking, and in the transit. And also they use the mobility in Twitter and in Facebook by the different states. And that was a very important complement, but obviously this is a complement and not a true substitution of the real surveillance systems. Again, they were very concerned about how they will be handling the deaths and how they will have, where they will be interred, and how it is at the cemeteries. And as you see, the timeline, how was from 100 cases to more than 500,000. Here is the comparison of the intensity of the cases, both at the global and in Latin America. Particularly Brazil, Mexico, Chile were very high, and obviously Peru and Ecuador has been suffering with a lot of cases and the inability to have the installations and the hospitals ready to keep the pace of the transmission. And I want to share that very recently, actually at the end of May, the advisory committee from Chile start providing a new guideline. And that's a very important lesson. When we review, and some of my students that were deployed for the Ebola in Africa, actually the rules and the recommendations changed by the week. We could not have one strategy implemented for the entire pandemic. We need to adjust it by the response, by the epidemiology, by the capacity, by even the behavior of the population. Then that's very important for all epidemiologists that are in surveillance, that we need to start adjusting, as some of the countries have been doing in Latin America. Here is, again, to demonstrate the difference of using mask and not using mask. And this was important because for many, many months until very recently, the assistant minister from Mexico rejected the use of masks. He didn't provide masks even for physicians, for nurses. And as you know, 20% of the cases in Mexico are from the health personnel, because the authorities did not believe that the mask will be protecting the population or the health personnel. But we have a very interesting approaches from the community. The community, without the assistance of the government or the authorities, start recognizing that they need to survive and they need to respect the social distancing. This is the example of Bolivia in the market. As you see, they are very trying to keep the social distancing. And this was a model that was also used in Thailand and in South Korea. And we think that was very important that even the community, without the assistance of the authorities, responded very well. What I want to mention is that in countries like here and in Europe, we are very clear that we need to characterize the expansion and the opening of the economy once that we know how much the population is infected, and we need to know the proportion of the new cases, and we know that we need to have at least a decline for 2 weeks, and maintaining that declining and having the use of the contact traces. As you know, Hopkins developed a course that now reach 300,000 students that are already taking. It's only 5 hours, but also there is another course that had been organized very good for the ASTRO, the Association of the State and Territorial Public Health Authorities, and they developed also a new course with now 18,000 people taking. But this is not in Latin America. In Latin America, there had not been any interest in having this type of training or deploying the contact tracing. We think that it's important to know the prevalence and the level of immunity, but in many countries in Latin America, still the authorities are rejecting that vision. They think that it's not needed, and as such, we see the explosion of new cases almost everywhere. And finally, I want to mention that even WHO, Dr. Carissa Etienne, that is the current director of PAHO, already declared that Latin America is now the new epicenter for COVID. And that's true. Now, the Latin America surpassed even the United States in new cases, and will require a lot of collaboration. And as you know, the United States and the President Trump is cutting not only the past, the current funding, but also has not been providing the funds from the last 2 years. Then the situation from the international organizations and the national collaboration in Latin America is highly affected. I want to show you what is happening today, and this is the information that Brazil is now very much speeding to become, now is the second after the United States, but it's possible that even surpass the United States. And you see the epicenters that are in different countries. Very interesting is to see Chile, that has a lot of cases, but very low mortality. And you will be asking me, what are the countries that have the best experience and has been controlling the pandemic? Well, there are two. I think it's Costa Rica and Uruguay. They have been very successful in keeping a very low number of cases and deaths. What lessons we are considering? Well, that first, public health surveillance is critical, is very important. We need to introduce in our schools of public health and medicine the full-fledged courses of public health surveillance. We need to also to recognize that when countries eliminate the full-fledged surveillance systems everywhere and keep the idea that sentinel surveillance is sufficient, we need to inform the public health surveillance in the sense of a sentinel are very good in specific groups and specific areas, but are not replacing the complete surveillance systems. For instance, in the United States, one mistake was that they didn't implement very fast, very quick, the sentinel surveillance in nursing homes. And that create these very vulnerable group, epicenters and hotspots. And the epidemiology was neglected because CDC didn't have a lot of influence in the authorities to modify the way to do this type of surveillance. In Latin America, very successful in some areas of Colombia and some areas of Paraguay, and even in some areas of Venezuela, they decided to do a lot of community-based surveillance systems. Means the ability of the community to go inside the families, and they are called in Colombia caminantes de la salud. They have been used for dengue. And now when I discuss with the epidemiologists in Brazil, they are very concerned because they don't have only COVID, they have also a lot of influenza because they enter in the winter, and also dengue. Then these three things are killing a lot of people, and the regular mortality that is for the other conditions are also been highly affected because the system is collapsed with the COVID-19. With that, I will leave here to allow some questions and comments, and again to thank Olivia Carter and the Department of Epidemiology for stimulating this type of webinars. And thank you very much for your consideration and attention.
Carlos, thank you so much for your presentation. You have given us so much information. I have tried to track down the contact tracing training that you mentioned for ASTO, and I put that in the chat box. I also put the COVID-19 infectious disease epidemiology course from Johns Hopkins in the chat box, and I also included the Johns Hopkins contact tracing training also in the chat box. And for those students who are interested in taking infectious disease epidemiology, we have a course that's offered jointly with the School of Medicine, and that's going to take place in the fall. So I included information for students who are interested in taking that. Now, from the questions so far that I've gotten, it looks like Dr. Daniel Robinson is on. He is in Rinovaque in Bolivia right now. And he has asked a couple of questions. He was interested in one particular slide that you had shown about how fast the different countries are going. I don't know whether Daniel has an opportunity. Mehmet, can we give him permission so he can speak? He can ask his questions. Great. Hey, go ahead, Daniel. How are you?
Hey, yes, quick question. The link to the slides I can get later, but here in Bolivia, clearly we've got two different situations going. We've got the lowlands of Santa Cruz and Beni, which are horrible. And we have the highlands, which appear to be kind of flatter curves under
Daniel, you're breaking
and
up.
you look at Peru. And so there's
Daniel,
so you
broke up. Daniel, you broke up, so you may have to repeat that. You broke up. If you could repeat your question.
I don't know if
I'll compose it and
okay.
type it.
Yeah, but from what you mentioned, I thought that we need to consider that division of the country is not sometimes sufficient. As you indicated, there are some areas in Bolivia that are highly affected, in which the transmission and the infection is extremely high, as it is in Peru. Sometimes in Peru, they ask me why we have so much infection even in Lima. And we start discussing that there are several reasons, but one is that the crowdedness of people. Once that a person is infected and we tell them, go and do a quarantine in your home. And in that home, there is 8 to 10 people. Then they could not have the luxury to have been in one single room. And that is the contradiction of our intervention sometimes, or recommendations. And the other thing is that the impact of the informal economy, they need to go out, and these two conditions explain why in many cities in Latin America there is a lot of disproportional number of infection in some specific neighborhoods in which we have lower socioeconomic people, but also highly affected by the informal economy.
So Carlos, he was able to send a chat message. He said the Amazonian areas are out of control. This is similar to Peru and Brazil. Why would this be different than Africa?
Well, first of all, in Africa, we start having a lot of the problems, but the vulnerability of the Amazon, as we know, they had been, the immunological response from them is they are more vulnerable, and they don't have the ability to have even the services and to recognize something that Brazil did in the past. They create something called the Trans-Amazonic Surveillance System. Unfortunately, this president disestablished that. That was very important for the monitoring even of dengue, malaria, and many other conditions. Why there are differences in Africa? Well, first of all, Africa are only starting to test and to have documenting the infections. And now they are facing again with Ebola. The Ebola had been last week having again hotspots and the reemergence of the epidemic there.
Thank you so much, Carlos. I know you and I had talked before about the indigenous communities as being particularly hard hit. Have there been any best practices that you can share? We are going to have another presentation that will look at some of that, but I was thinking from your perspective, what you've heard.
Yeah, well, it's important to, even as educators and faculty, we need to make sure that the message for the population and for our students and other faculty is that social distancing will be for a long, long time. This is the new normal. And we need to convince that social distancing is needed even when the vaccines will be available. As you know, 40% of the population in the United States already indicated that they will not be interested in getting the vaccine. As you know, in order to get the herd immunity, we need at least more than 90%, and we would not get it. And in that sense, the recommendation that we are now very clear is that social distancing will be for a long, long time. Other of the, what happened in 1919, they kept these measures for a long time, and use of masks, cleaning their hands. The only thing that I thought that was interesting is the recommendation of aspirin, but the recommendation of aspirin creates a lot of problems and a lot of mortality because they use too much. And then some of the people die, not because of the influenza, but because of the aspirin. Then the other thing is we will need to change our way to teach. Hopkins still is now implementing all our courses, not only will be online, but will be through Zoom to facilitate this transfer of avoiding the social distancing. The other thing is that people, one of the messages that we had been putting a lot is that opening the economy does not mean that the risk is less. Actually, may be increasing the risk. And people if we are not telling that opening the economy is part of a political and economic strategy, but is not to say that we don't have any more risk. The risk could be increasing. Then social distancing, masks, and all the hygiene will be even more important. In all the pandemics, I have been reviewing all the pandemics, always there is a second wave. Then we need to be prepared. I think one a problem with the opening of the economy is giving the sense, the wrong sense of security. And we need to prepare for the second one. And that's part of the message that we need to have. Also recognize that never in the history, the scientists across the globe, in spite of terrible leaders, they have been working to provide all the knowledge in a very short time. Having in some weeks the genome of the COVID, people should be so grateful. And to have the national history of COVID by the Chinese epidemiologists with other scientists of other countries in a very short period of time. And all the things that have been done in a few weeks or months that took in the past years and years, then we need to take also that perspective.
Thank you, Carlos. It makes me wonder, what sort of good news would you be able to, after these many months of working together with these epidemiologists, are there any good news that you can share with us at this time?
Yes, I think the good news is that this virus is not more virulent, and the very good news is that the social distancing and the masks are very protective. There's a prevention that is available. And this is very good news because has been avoiding a lot of cases. The other thing is that some groups that for us are very important, like children, has not been highly affected like in other diseases. My concern is measles, that perhaps many children in the United States has not been vaccinated, and for the mortality that is from other conditions that has been neglected. And now there is a lot of interest in measuring. What is a good thing is that in spite of everything, some segments of the population are behaving and are accepting that is important. Two things: changing the leadership is needed. As you know, not using the pandemic team that CDC used to have was a mistake. That a lot of knowledge was already accumulated there. And maybe people will understand now that some of the policies were wrong, not because we lack of information and knowledge, but because of political decisions.
Thank you so much, Carlos. I just want to let anybody know, if you have a question, please take advantage of the chat box or raise your hand. There's so many on here, I may not see with the raising hand, so take advantage of the chat box, and that way we can try to address your question within the remaining 10 minutes. Carlos, you have had at least 2 different careers. You worked at PAHO and now you worked in academia. What sort of skills are you drawing upon? What sort of training are you drawing upon that you would suggest to our students who are interested in doing this kind of work?
Well, you know, public health is so broad and have so many areas of expertise that are needed, but we need to decide, and that's even a challenge that institutions like, I guess, University of Maryland and Harvard and Hopkins have, is that we need to train apply epidemiologists. And I think when I mix my experience at PAHO, let me give you the reason why we developed this training of senior managers. With the director of PAHO, we start recognizing that we hire a lot of PhDs from EPI. And when they confronted with the ministers, they always thought about developing a cohort study or case control. And the ministers told them, no, I need the recommendation for today, maximum 3 days. And they say, I don't know how to do it. I don't know how to use incomplete data. I don't know how to respond to the minister. And then the minister asked me to release that epidemiologist from the country, and took like 50 after I need to change and move 50 epidemiologists that were highly trained. I discussed with them and say, I don't know how to do these things. Then the idea that apply epidemiology and apply public health is essential now, because we need to solve problems. And we have accumulated so much knowledge and information that we need to implement it.
Thank you so much for bringing that up, that important point. I'm going to put in the chat box a link to the American College of Epidemiology's Policy Committee. They published 12 case studies as well as other papers on lessons learned from the translation of epidemiologic research into policy and practice, because we recognize in the training of epidemiologists, we fail to communicate how to work with policymakers. Policymakers have a very different time frame than we do. Both you and I have worked in policy offices, so we understand the need to learn that language. And so I'm going to share that in case anybody is interested in those lessons learned.
Excellent. Well, very good, Olivia.
Ed, anybody else have any questions?
I don't know if I respond to Daniel.
He just said, if the consensus among epidemiologists around the world is that masks are working, is there an authoritative document that reflects this? There's still conflicting views with data to back it up.
Okay. Knowledge change, reality change, then and at the end, as you mentioned, policymakers, we don't communicate very well. I remember at PAHO when every year we bring all the ministers in September into Washington, and they were so bored when we present all these epidemiological assessments of 200, 400 pages. What they need are executive information and advisors that will translate part of the knowledge into policy. And this is very important for our new training programs.
Thank you, Carlos. There's another question. How can these messages on COVID-19 prevention be applied to Latin Americans living in the United States?
Very important question. Currently, as Olivia knows, the American Public Health Association create a task force of the Latin COVID group. And this is now like 80 professionals that are linking with the different NGOs and official institutions that translate messages and provide some services to the Hispanics. As you know, the Hispanic community is highly affected in most of the cities, and we think that it's essential that this task force and many others that are now developing the supporting, even CDC is now releasing a lot of the materials in Spanish. Important is how this will be communicated. Some of my students now are being part of the contact tracing in Spanish, because that's also very important. I think the messages sometimes even in the discussions with this task force is that they want to give the messages in the language of the different nationalities, like it's different for the Peruvians, the Mexicans, the Colombians. But I think the pictures are speaking by itself. Sometimes we need to communicate by pictures, and has been very effective for centuries. Even I always put the example of the subway in Mexico City that only use pictures or pictograms. And the majority of the users in the past, they didn't have the ability to write or read, but they were able to handle the subway system because of the pictograms and not because of the wording.
Thank you so much for bringing that up, Carlos, because you may not know, but our school, Public Health, has the first academic center for health literacy in the country. And one of the things that we observed is that the literacy level of the materials that are being disseminated, such as from CDC, have been very high level. For instance, the webpage for CDC on testing, if you run the literacy levels, it's 11th grade or higher. Okay, so way too high. I think these are important messages that we need to learn also how to communicate information. Raul Cruzcano, who's one of our faculty members, is asking a question. Despite everything that Mexico did wrong, it seems to be doing better than the United States did at the same point in the epidemic. What happened? Is the worst yet to come? Is the population density of affecting the outcomes that much? Or as you were saying, is there an issue with the data?
Well, the data is a big issue according to different epidemiologists, authorities, and there is a lot of conflicts between the federal government and the governors of the states. The governors of the state, and maybe that's a very good point of the question, 3 governors went against the president and the federal government and start implementing the interventions of social distancing and mask and all of that in these 3 states. These are the 3 states that have the lowest number of cases and mortality because they start earlier. And as I showed in the presentation, the curve has not been flattened. It still is growing. And what sometimes the government is presenting is the projected from their own data. But remember, they use a probabilistic approach. They don't test the country. They test only 400 localities. And this is a very good approach for influenza trend assessment, but it's not for a new virus or new agent, because everyone is susceptible. And with influenza, there is a lot of people that already have been vaccinated. It's a totally different than using sentinel surveillance is good, but using for COVID is not. And as such, they are not putting the real data into their own official statistics.
Carlos, thank you so much. We are right at 4:59, so I'm going to turn it back to you. Any last words you would like to share with folks? We just see this as a beginning of a dialogue, and we encourage people to join us for our remaining seminar series and to view the ones that have already been taped. So, Carlos, any last words?
No, congratulations again. I think it's very important, this type of exchanges, and I hope we will be able to coordinate and to maybe generate some studies to approach the Hispanic in the United States and in our area. We are working with the children of Central America in Baltimore City that we will be discussing with you in the future. And thank you very much for the opportunity to share with all of you the information about our network of epidemiologists in Latin America.
Thank you, everyone, and we hope you stay safe, and please join us on Monday as well as for future webinars. And Hongjie, did you want to say anything, my chair?
Yes. Hi, Dr. Castillo-Salgado. Thank you very much for this great and informative presentation about the epidemic in Latino Americans. As department chair, I want to thank you on behalf of the department. Thank you.
Thank you very much, Dr. Liu. Excellent. Very good.
Thank you, everybody.
Very good.
Ciao, ciao.
Bye.